Yes, Wendy. Yes, it's here. Okay, we are going to get started. People will join. Some people already messaged me that will be late. Thank you so much for everyone who made the efforts to be here. This is a meeting that is virtual. It's one of the first meetings of OMERACT, I think every 2 years, that is virtual and not in person. So I hope we can really have very good discussions. So we are going to have three patients who are going to join us and are going to share their perspectives from the patient point of view. And one of them is Janet Gunderson. She's from Canada, from Saskatchewan. Another one is Simon Stones from United Kingdom. Another one is Wendy Osler from Netherlands. And I and Marion will be facilitators of the meeting. The content expert is Dr. Robert Lambert from Edmonton. And the students are Tarimobo Tobo, who is responsible for the sacroiliac joint working group, and Mirkamal Toland, that is responsible for the temporomandibular joint group. The focus of today's meeting will be the sacroiliac joint. I'm just going to share, I think, a couple of slides with you, just to show you what is going to happen during this meeting. And after that, we're going to have very brief presentations. And the purpose of this meeting is to really spend more time in terms of discussions. So I'm going to share my screen, and hope you are able to see my screen and my. Can you see my screen? OMERACT MRI in JIA.
Yes.
Yes.
Okay. Okay, so this is the agenda of today's meeting. We are going to discuss the Atlas of MRI or Juvenile of sacroiliac joint. Jacob is the one who is going to present, and he and Nelly have both contributed for the organization of this presentation. Tarimobo Tobo, who is a graduate student, a PhD student, is going to talk about reliability 1 exercise, some results, what did not go well, and it would be very nice if everyone could share your perspectives on how we could improve the methodology of the future reliability 2 study that should start in early 2021. Dr. Walter Maximovich from Edmonton is going to talk about calibration models and lessons from previous studies. And then Mirkamal Toland, who is a PhD student, is going to share the methodology of face validity that was used in a previous study from the temporomandibular joint group in terms of the design. And we hope we are able to have very good discussions. So in terms of the lessons learned from the imaging outcomes of the OMERACT is that the initial step or the initial lesson would be to detail domain definitions for an scoring system, the domain match. Then the second lesson is to try to understand the sources of variability of measurements and how these could impact on the results of a study. And the third lesson is the OMERACT Filter 2.1 instrument selection algorithm, it's called OFISA, which has been developed specifically for, I think, for an imaging outcome measure. So sorry about that. Sorry about that. So in terms of the 2 domains that we have one inflammatory and one damage domain for the sacroiliac joint MRI scoring system. This is a preliminary scoring system, and the inflammatory domain that Tarimobo is going to discuss in detail has different items, bone marrow edema intensity, depth, capsulitis, joint space fluid, joint space enhancement, inflammation in an erosion, and enthesitis. And the damage domain has components or items such as sclerosis, erosion, fat metaplasia, backfill, and ankylosis. In terms of the sacroiliac joint inflammation, and just regarding lesson 1, there are different levels: core area, broad domain, target domain and domain components. Considering manifestations and abnormalities as the core area, the broad domain is joint inflammation detectable by MRI. The target domain from the perspective of technique is bone marrow edema, for example, this is an example, detectable by MRI, and the instrument is osteitis. And regarding the domain components, MRI detected elementary components of bone marrow edema, and the operational definition in terms of the instrument is what we see on MRI. We see a low T1 and high T2 signal on MRI. So these are some lessons, lesson 2, the sources of variability that affect imaging instruments. And we have different sources, target domain, image method, reader, technician, patient, disease, and this will be discussed by Tarimobile later on. So how can we now match the filter 2.0 to the filter 2.1, which is the current filter that is being used by the OMERACT group? So we have here the previous filter that had 3 components: feasibility, truth, and discrimination. And now there is more information or more detailed information about how can we use this information in clinical trials. So number 1, is it a match with the target domain, the truth? And this is what we did when I think we tried to think about definitions for an MRI scoring system of juvenile, of sacroiliac joints. Is it practical to use the feasibility? So for any exercise, we need to see what are the minimum sequences that should be present for us to be able to interpret an MRI scoring system of sacroiliac joints. So we discussed that at least we need to have coronal, oblique, T1, and T2 weighted imaging. And all more details about the protocol will be discussed later on when we have more information from the reliability studies. So we plan to revisit this in this working group in the future. Do numeric scores make sense? So this is about the face validity, and this is something that we're going to start discussing today, and we're planning to really conduct an exercise in the near future. And then, can it discriminate between groups of interest? We started already looking at the reliability of the MRI scoring system, and we plan to further refine this information in the future as well. And the feasibility we're going to revisit in the future: should we use contrast enhancement for sacroiliac joints, MRI or not, and other specific points. So where are we in the process? So just to give you a big picture of where are we. So the step 1 is to have a systematic literature review of what are the scoring systems that are available for assessment of sacroiliac joints by MRI in the pediatric population. And there is a systematic review that was published by some components of the OMERACT group, not all of them. And they just mentioned that there was no, at that time, there was no specific MRI scoring system that had been really used for assessment and in pediatric population. Now we already have changed, but at the time of the literature search, there was none. Then the step 2 is about the Delphi exercises that were done in terms of obtaining the correct definitions for the different items of the MRI scoring system, which is something that was published in the Journal of Rheumatology in 2019. And then the reliability 1 exercise testing this preliminary MRI scoring system is something that we're at the point of finalizing the reviews of the manuscript and plan to submit soon for consideration of publication. And today we're going to discuss all the problems that we had in this initial reliability study. And this is something that Tarimobile is going to discuss now. So thank you. I'm going to stop sharing. And I'm going to invite first Jacob to talk about the atlas of MRI for sacroiliac joints. And after that, Tarimobile is going to discuss the results of the reliability 1 exercise. So Jacob, if you could share your screen.
Yep. Okay. Can everybody hear me okay? Okay, great. So thanks very much for inviting me to present here. I'm presenting on behalf of myself and Neela Haragods. We've been working on an atlas. This is actually, I would say, primarily Neela's work, but we've been working quite closely on it together. An atlas which depicts visually the findings that that we're looking at for scoring. So our purpose here is just an introduction to show you what the pictures look like, and so you get a feeling for what the what each of the imaging features are. And I think that informs the background of the entire session. So first of all, you know, the standard technique historically for evaluating the SI joints has been radiographs. And these, here are some examples in children showing normal versus abnormal. So on the left is a child with normal SI joints, and on the right there's a case where there are irregularities of the SI joints with marginal sclerosis and likely some erosions. Now, for someone to get to the stage of being radiographically abnormal means there's quite well-established structural damage from long-standing or quite aggressive sacroiliitis. So radiographs are not very sensitive, especially in children. So people are increasingly using MRI, which is why we're looking at MRI. So just to give you some examples of MRIs in children, we have numerous slides in this presentation. Now, interpreting these MRI is difficult because there are many normal variants and because the children are still forming their SI joints. So the margins of the joints in younger children are still cartilage, and even the sacral ali, the intersegmental joints, are still forming. And there are many changes at the metaphyses or metaphyseal equivalents that can mimic pathology. So here we have an example of a normal pediatric SI joint. We have a T1 and STIR semi-coronal images, and you can see the bright lines along the edges of the joints, which is actually normal subchondral signal change, kind of like the bright lines that you see on metaphyses at the knees in children of this age. And then on the T1 sequence, you can see the irregularity and blurring of the articular margins because essentially thought to be because of combination of volume averaging and you know, incomplete ossification at the articular margins. So these pictures are difficult to interpret, and even more difficult to interpret than the adult SI joints, in my opinion, anyway, and have led to lots of controversies. As patients get older, this is a 15-year-old boy, and you can see that these changes sort of settle down a little bit as a patient becomes closer to adulthood. So those metaphyseal flaring changes on the STIR get less, or the periarticular flaring. And then the T1 images, even in an older child, in a teenager, you still see some irregularities of the joint line and some blurring of the articular margins. So this can be pretty confusing. Now here's a patient with clinically diagnosed spondyloarthritis, so they're 16 years old, JSPA, and there are numerous findings here that are abnormal. So there's asymmetric patchy edema in the iliac, right iliac bone, and in the left iliac bone as well. There's fluid in the joint, there's capsular thickening and fluid. And then on the T1, you can see an erosion that's disrupting the cortex. On the right superiorly, and on the left superiorly, you can see some sclerosis. And on an axial image, we can again see these capsulitis. So this is someone with very clear pathology, shouldn't be too much of a diagnostic dilemma. Here's an example of erosion. So you can see that the articular surface is getting disrupted with sclerosis underneath it and edema nearby. And that's what it looks like on T1 and STIR. But notice how the other side on the right looks still quite, you know, looks a little bit unusual if you're used to looking at adult MRI. There's some ill definition and irregularity. So the current situation is that MRI is increasingly relied on for diagnosis and management in JSPA, but there is a lot of confusion as to normal variants versus pathology. And there are some issues with variation in scan protocols across centers. And when you put all this together, the current MRI SI joint interpretation is really an art. That's why I have a picture of let's say that's a radiologist painting at an easel, producing an artistic impression of the patient's SI joints. So this is great if the experts can be reliable and reproducible, but our goal in OMERACT is to find a more objective and more broadly applicable approach. So the JAMRI SI joint scoring system that we've been developing in this group has evolved, and the rest of this presentation I'll just show one by one the features of sacroiliitis that we see on that. So we'll go one by one. Just like the list that Andrea just put up, there's an inflammatory domain and a damage domain, numerous findings in each, and we'll touch on each of these individually. The most important is the first one in each, so bone marrow edema in the inflammatory and erosion in the damage domain. Now, all of these we decided as a group, all findings are to be interpreted in comparison to physiologic changes normally seen in MRI of age and sex matched children and visible in two planes where available. So that's kind of a disclaimer that goes on all of it, because there are these physiologic changes and we have to interpret based on that. So here we have a patient with bone marrow edema, a couple of patients actually. And so you can see that there is a very bright signal underneath the, in the periarticular bone. And let's just read you the definition here. I'll go forward and say that there's, let's just go here to the summary and I'll just give you the definition, then we'll back up. So the definition we came up with is an ill-defined area of high bone marrow signal intensity within subchondral bone in the ilium or sacrum on fluid-sensitive images. So backing up then, here's the ill-defined area of high subchondral signal in the STIR sequences. So all of these areas, I think, pretty obvious to any observer. If you look though at the normal patients, there are these areas of ill-defined increased signal that one might call BME, and we often get referrals from the periphery from people who call this stuff BME. However, if you use the overarching consideration in consideration of physiological normal variation, then these symmetric findings are not actually pathologic. So now, as coincidence would have it, just last week, this became published online, a paper done by Neela and myself with numerous collaborators, some of them in this group, thank you, looking at the normal variation of subchondral T2 signal versus BME. And what we found is that this rim of subchondral signal is commonly observed. It's much more common at the sacral side. So 3/4 of sacral SI joint margins had some of this flaring, but the iliac side was only seen in 1/6 of patients. Some usual patterns that are suspicious for pathology are if there's an asymmetry between left and right, if the iliac flaring is more intense than sacral flaring. So it's pretty unusual to have that. And to see if there's definite flaring in older teenagers after sacral apophyseal closure. So if we back up and look at this, these patients here, you can see that the sacral side is much more intense than the iliac side, where there is virtually no flaring. So keep that in mind. We do have some criteria that are evidence-based for distinguishing normal flaring from bone marrow edema. And we have our definition, ill-defined area of high bone marrow signal intensity within subchondral bone on fluid-sensitive images. There are some extras or sort of bonus points on the bone marrow edema scale. We look at bone marrow edema intensity. So presence of hyperintensity considered as bright as fluid elsewhere in the scan, and then bone marrow edema depth. So that's where it's more than 5 millimeters to 1 centimeter from the articular surface. And there's some criteria for age as to when to use the depth. So if someone has really a lot of marrow edema, then you can score those two findings. So we'll move to the other sort of classic finding, which is erosions. And erosions, you kind of know them when you see an artistic point of view, but actually we've discovered in our reading exercises that everyone knows them quite differently. It's very difficult to score erosions reliably. So here are some cases. I think the top right one is the most obvious. You can see these indentations in the cortex under which there are signal changes, and there's a full thickness loss of the dark cortical margin in these areas. And some of these erosions on the T1, have sclerosis underneath, and some of them have fat underneath. And there are some erosions that are smaller, and there are some areas which are questionable with blurring. So Now, in pediatric SI joints, that blurring I was showing you earlier is an absolutely crucial finding. There's blurring and irregularity on these patients who are clinically normal, and it really is difficult to tell this apart from erosions. So the definition we've come up with is a focal loss of the low signal of cortical bone at the osteochondral interface and adjacent marrow matrix on T1 weighted images. So it's focal, it involves the osteochondral interface, and it involves something to do with the marrow underneath it. So you need all those findings on the T1 to define it as an erosion. There's a kind of related finding of osteoitis, which is if we do have contrast enhanced images where you get this marrow signal intensity in subchondral bone, if you happen to have that sequence, but not everyone does contrast enhanced imaging. There's also capsulitis, which is a setting of increased signal on fluid sensitive or contrast enhanced T1 weighted images involving the superior portion of the SI joint capsule. And that first case I showed you was a classic example of that. So there we see, now this is a relatively less common finding, but when we do detect it, the capsule is distended just like other synovial joints in the periphery. Joint space fluid is interesting. We've defined it as high signal intensity equivalent to CSF on fluid sensitive sequences within the joint space of the cartilaginous portion of the SI joints. So on the right, we have someone who has JSPA, a 12-year-old girl. And on the left, we have a normal patient who does not show those bright vertical lines. Joint space enhancement is, again, if you have gadolinium enhanced scans, then sometimes you're going to see bright signal in the joint line post-gadolinium. And so joint space enhancement is defined as increased signal intensity on the contrast enhanced sequence within the joint space. And there has been controversy about what the cause of that bright signal is. I won't get into that, but that's just the definition. Now, interestingly, normal patients also demonstrate high signal and sometimes even bright signal post-gadolinium within the joint space. So here's a 14-year-old boy who's normal clinically, who has this same bright vertical line at the joint space. And then we have a 13-year-old normal boy who does have these T1 hyperintense lines along the edges of the joint space, which might be on the cartilage borders post-gadolinium. So there are many technical factors and anatomic factors that may be leading to this appearance. So for purposes of further study and discussion, we've objectively defined these features. Another one, which is felt to be quite important in pediatrics, but is not necessarily as well appreciated as it should be, is inflammation in the erosion cavity. This is where you have increased signal intensity on fluid sensitive or contrast enhanced images in an erosion cavity. So you have a hole in the articular margin and it's bright in the middle of it. And so if you see that, that's a pretty good sign there is SPA, and we are now categorizing that. Some other peripheral findings include enthesitis, which is increased signal intensity in bone marrow or soft tissue at sites where ligaments and tendons attach to bone. Now, interestingly, we do exclude retroarticular enthesitis, and that's an interesting one that may not be universally appreciated. But once you're outside the SI joint, so this looks like some people might think at first glance this is the SI joint margins, but we're well posterior to the joint and we're into the cartilage, into the enthesial portion of the joint. So they're just a bunch of ligaments between the bones here. And so when you have edema at the edges of these ligaments, those are actually entheses. However, we're excluding the retroarticular ones. So a more clear-cut example of enthesitis would be if it's at the iliac crest or at the trochanters. Another structural finding is sclerosis. And so here we're looking at a wider than normal area of very low bone marrow signal intensity. So you get subchondral sclerosis. It's a thick, dark area, usually seen on the iliac side at the edges of a bone that has at the edges of a joint that has a chronic sacroiliitis process. Notice that a normal patient does have a little bit of thickening of the superior iliac margins, but the people with SPA will get more sclerosis if it's a chronic condition. So this feature needs to be present on all sequences because a dark area of decreased mobile protons will be dark on everything. And so we've defined it as sclerosis when it's dark on all the sequences. Conversely, subchondral bone in chronic disease can develop fat metaplasia or fatty lesion. So once the fire has burnt out, then you're left with a sort of a dead forest, and the marrow becomes just filled with fat. And so the definition is homogeneous increased signal intensity within subchondral bone marrow on T1 weighted images. This is a finding that's more common in adults and the very oldest children that we image. We'd see a lot less of it in younger children. And another finding that's really classic in adults.
We have like probably 2 minutes because we need to discuss a little bit. Okay.
Perfect. Yep, we're almost done. I think this is possibly my last slide. Backfill is a finding that's more, again, more seen in adults or chronic disease where you have a bright T1 signal within the joint. It's kind of a lengthy definition, but it's a tricky finding to make. And of course, the last finding is ankylosis, where the joint just completely, the joint line is lost, continuously bridging marrow signal. So here's one page, unreadable, with all of the definitions summarized and with the way we score them. And essentially, that's the atlas that shows all the imaging findings. Just to summarize, there are findings in bone marrow. In the bone marrow, edema and erosion are the most important, but we have inflammatory and structural domains. Lots of points of controversy and challenges with normal variation versus pathology in all of the areas.
Thank you so much.
Thank you very much.
Yes, thank you, Jacob. It was a very descriptive and excellent presentation. Thank you so much. We have one question from a patient, and this could be answered for either, I think, you, Nelly, or Robert, or any other person. How well trained are radiologists to read X-rays and MRIs or sacroiliac joints in kids?
That's an interesting question. I think the training is variable worldwide. The people who are most likely to be well trained in this are people at large centers that have a good referral basis where they see lots of patients with it. Everybody gets some exposure during the training, but it really requires experience. So that everyone learns the basic principles of it in your residency or in your fellowship in pediatrics. But we think that even with that basic training, you really need a lot of experience in this.
Mm-hmm. Thank you. There's another question from Mada. Why have you decided to exclude posterior enthesitis? It may be a cause of pain and inflammation, and there may be causes, I think, why is important to clinically call enthesitis. I think that the reason for excluding some aspects should be clarified at the beginning of the protocol.
Actually, Andrea, could I be permitted to address that?
Yes.
Because it actually involves some work that we did with Mada, with the EcoSPA cohort that she put together. And we actually compared the detection or assessed the detection of enthesitis detection in the ligamentary compartment of the joint. And we could not detect it reliably, and for 2 reasons. One is some people would score bone marrow edema that you often see in the ligamentary compartment as a component of enthesitis. And the vascularity that you normally see in the ligamentary compartment increased, can be confused with the increased signal that you'd see in a stir sequence. So our reliability for detection of enthesitis, at least in adults, was very poor indeed.
May I just comment and ask a question? I agree that we can decide, or you can decide, to eliminate some lesions that they are not reliable. Probably at that time the definition was not clear and they probably can be reliable. But I think that when we are validating an instrument, we have just also in the protocol or in the paper to say that the choice of some lesions to be included is based on some aspect, reliability, feasibility, or whatever. This doesn't imply that this should be the only one detected in clinical practice, because I have seen so many times that the scoring system developed for research or for clinical trial are then applied to clinical practice. And then in that case, the images is defined as negative, when negative is not, because this can be a cause of sacroiliitis. I was typing very fast. Clinical sacroiliitis, and clinically can be performant and can be useful. So for me, what it is really important is what we are using and defining for research as outcome measurement instrument for clinical trials, and what it is useful for clinical practice. And sometimes we have a mix of these 2 points.
Thank you so much. So now we're going to move to the reliability 1 exercise. Terry Mobile is going to present. Terry Mobile, please feel comfortable to share your screen. Thank you.
Okay, mission accomplished, Monique. So I'm sort of more around now.
Oh, sorry. Okay. Hi, good afternoon all. My name is Tarimoba Michael Otobo. I'm a PhD student under the supervision of Andrea Doria and as well as the fellow for the SIG project. Today, as part of my presentation, I'm going to be providing a very quick overview of the development of the JAMRI scoring system, which is juvenile arthritis, MRI, sacroiliac joint scoring system, and as well as the initial pilot inter-rater reliability study that we conducted. So we had started the process of developing a scoring system, given some of the gaps of an imaging-based dedicated scoring system for the sacroiliac joint for children with juvenile idiopathic arthritis. At the time, an initial systematic literature review was conducted as part of evidence to select existing measurement domains and as well as component items to be included. And then in addition to that, we had a draft scoring system items and definition. And these, in addition to multiple focus group and nominal group discussions, we were able to arrive at the version 1 of the preliminary scoring system, as I'll be showing subsequently. But through this over 3 years, going 4 years right now, we've made significant progress. And so one of which we have done was that to test the initial preliminary version 1, and which is the results I'm going to be talking about in the reliability 1. And we did identify a couple of pitfalls and as well as challenges in the scoring system, which also will be discussed. As a result of that, we thought that in order to improve the scoring system, we needed to develop an imaging aid, which is what Jacob just presented about. And so we're thinking that in addition to the imaging aid, which is the atlas of the JAMRI scoring system, and as well as the revised scoring system, giving the lessons learned from reliability 1, we will be, executing a reliability 2 exercise to see how these items are performing. And also, we're thinking at this initial phase, we can, in addition to the fact that we had a more robust consensus discussion, we wanted to kind of estimate the phase validity in a more data-driven way, and that is what Mia Kamal will be talking about in the phase validity exercise. Our hope is that by the end of this exercise, we should be able to move on with the evidence to kind of talk about longitudinal and the discriminative properties of the scoring system. The JAMRI SIG overlaps with the measurement domains of OMERACT. So the core area is manifestation abnormality, and the core domain area is to look at inflammation and as well as damage of the sacroiliac joint. And as well as we have the theoretical definition for each of the component items. Pardon me, I'll just quickly go through what each of these mean. And of course, they correspond with the operational definitions that we're looking at. So we have bone marrow edema, osteitis, joint space fluid, joint space inflammation, inflammation in erosion cavity, capsulitis, enthesitis as part of the inflammation domain. And we do have erosion, sclerosis, fatty metaplasia, lesion, backfill, and ankylosis for the damaged domain. So each of these constitute what the Sclerosis system is all about. And we do just wanted to provide an overview of what we've done so far and how that overlays into OFISA 2.1. At this point in time, we do have we could assume, given the rigorous nominal group sessions we had, that currently the definitions we have do match the target domain that we're looking at this point in time. And given the initial pilot study we had, that could suffice. And perhaps also we have gone through a second iteration to kind of improve some of those items. At this point in time, too, the Reliability 1 study overlies with OFISA 2.2 item, which looks at if the numerical scores making sense. And these are some of the things that we've been working on for some time right now. So this is just a schema to look at what has been going on. And so after the initial multi-stage consensus process, we did arrive at the version 1 of this current system. And we had the initial Reliability 1 study, which was typically was the pilot study, because this was the first time we're going into the field to kind of test the definitions. And so as a result of that, we identified sources of variability, and which I will be talking in subsequent slides, and address those sources of variability in multiple ways, one of which was to go through additional consensus process to kind of improve the definitions. We did add some additional items to kind of to broadly be able to capture the disease that we're trying to measure. And now we do have the version 2, which obviously needs to be tested again. And we're in preparation, just as you would hear from Walter in his presentation, and how we can optimize and increase the reliability of the JAMRI scoring system. And so the development had started, like I earlier said, 3 years ago, and these are some of the components of how we arrived at the measurement domain, and as well as the component items. 25 invitations were sent to experts across over 3 continents, and just the distribution of where the experts were coming from. And after multi-iterations, we had a draft version, which constituted these items. For the sake of time, I may not want to go into them. So, but this is the version 1 items, as you will see in subsequent slides. But then this is just a slide to show you the relative participation for each of the rounds that we had. So it gives you an idea how rigorous, we've been going through. So each items here tells you how many times that we have met, the percentage participation for each of our meetings, both in person and also virtually online. Oh my God, what happened? Oh my God. Hello, can you hear me?
Yes, we can hear you.
Oh, I don't know what happened. Screen sharing has stopped. Okay. Can you let me share my screen again? Sorry about that hiccup. Sorry about that. I just had a little hiccup here. Yeah. Can you see my slides?
Yep, perfect.
Okay, so this just gives you that, and so it's been quite a rigorous process. We've been going back and forth trying to improve things, and now we have the version 2 of the JAMRI scoring system. So this is the version 1 of what upon which we had the reliability 1 study, but now the version 2 is what we're working on right now. So based on these definitions and response options, we were able to conduct the reliability 1 study, and this is just a snapshot of what the study design was. And so initially our intention was to kind of design the study in a more in a statistically compliant manner. And so we had subjected the sample size estimation using the Donner and Elowitz formula, which provides a framework for a reliability study that is adequate, given results available. I mean, you would imagine that if you're going to be estimating reliability studies, you might run into a situation whereby, in order to have to meet a particular statistical power of the reliability estimate, in this case we're using the ICCs, there might be need to perhaps increase the sample size. But because we do have peculiar challenges with case distributions, we wanted to kind of justify our sample size. So we had used the an evidence-based method to arrive at that. And based on that, we decided that we're going to be using 30 MRIs. These are the sequence protocol that were accepted, and we had 3 readers, 6 radiologists and 2 rhematologists, and we did estimate
2 more minutes. We need to have questions and then move. Okay.
So we now had to use model 2.1 for inter-rater reliability, and so we did set our initial acceptable ICC to be 0.7 at the time, and these are just some of the inclusion and exclusion criteria for this study. And so this is just a summary of the ICCs and perhaps some of the distribution of the scores that we had. Bone marrow edema did actually meet our pre-specified prior hypothesis of 0.7. And so just showing those items in green, and of course the others in red. But during the debriefing of these results, we found that some of our design methods may have perhaps underestimated the acceptable ICC, and so we think that some of the learned lessons are going to inform our study design in the reliability studies. But of course, as a result of this performance, most of these items have been revisited, revised, and now we do have a different response option and as well as definitions for each of these items. And so some of the sources of variability that affected the score include operational definitions, which currently have been revised in the version 2. We do have imaging and scoring method, which currently also have been attended to. And so now we have a revised scoring method and specifying additional scans for each of the items. Sources of variability associated with the reader / rater has to do also with the definition of the target domain and as well as reader training. As you would see, Walter, who have many years of experience in this area of research, is going to be leading discussions in how we can develop calibration models to optimize readers in a subsequent reliability 2 study. And of course, we do have challenges with case distribution, which of course affects the reliability estimates using ICC. And we're thinking that as part of correcting for these, we're going to be assessing cases in true multi-center contribution. So in conclusion, in our scoring system currently, bone marrow edema and Ankylosis did achieve per set ICC cutoff of 0.7 or greater than 0.7. The others didn't meet this pre-specified ICC. However, that doesn't mean that their performance is poor. It's just because of what our research questions were at the point in time, and we thought we could improve this in future. And of course, case distribution was a huge challenge, and it contributed to source of the variability in the score. And our future direction in this research work is to execute a reliability 2 study, given the revised scoring system that we have, and as well as with a measurement aid, and as well as using a calibration of readers that are going to be in the next reliability 2 study. So thank you for listening. This is just to acknowledge all the contributions for our partners, and as well as some of the funding agencies that are providing funding for me during my training. Thank you for listening.
Thank you so much, Terry Mobile. It was great. So does anybody have any questions to Terry Mobile? I have one question, Terry Mobile. So you just mentioned the ICC for this reliability one study for bone marrow edema was more than 70%. And I think Jacob showed, I think some limitations of the atlas. I think one of them is bone marrow edema, because according to the age, we may have different normal patterns of bone marrow signal on MRI. So do you think that this is, the results that we had in this study were related maybe to the sample, that is just like a small sample of patients, or is there any other reason for that?
Yeah, I mean, obviously, this scoring system is overweighted in terms of the contribution of BME in the scoring system. In addition to that, this is one item that has been quite consistent in other scoring systems. As you would imagine, the SPARC scoring system for children do have bone marrow edema as its component, and it has been well exercised. So reader competence is very high in this score, and so it is not unsurprising to have people kind of being able to read scans that have BME. And perhaps this is one of the issues that we have identified, because all of the readers that had participated in Reliability 1 were also participants in studies which BME had featured prominently.
Thank you so much. So now we're going to move to calibration models and lessons. I think Walter Maximovich is going to talk to us, and probably this will be very important in terms of improving the reliability for the second exercise for this MRI scale. Thank you, Walter.
Thank you, Andrea. Hello, everyone. Hopefully you can see my PowerPoint presentation there.
Yes.
Sorry, I've just jumped ahead a little bit. Right. So I'm going to talk about how I think we can make progress and what our next steps might be. So I think this is an excellent framework under which to think about the design of scoring instruments and their validation using the OMERACT framework. And something that's been emphasized, although I think it could be clarified further, is the importance of the two items I've highlighted in the boxes there. I think that as our methods get more complicated and as we incorporate more domains and definitions, it's very clear that everybody must have a good understanding of what it is that we're trying to score. And everybody should have a good understanding of the methodology, not just as it relates to definitions, but also the scoring methodology. And this, because of the interest in scoring instruments and their application in various roles across the world, it's important that we have a way of standardizing that knowledge and conveying that knowledge. And there have been efforts undertaken within OMERACT that provide an example as to how that might be done. I was just a little disappointed that that was not included in this framework, that in fact OMERACT has worked on this and publications have addressed approaches to standardization of calibration and knowledge transfer. So what do we really mean when we talk about calibration? A clear and consistent understanding of the scoring methodology. And what is particularly important for scoring instruments, I think, is establishing a uniform and consistent threshold for detection of the abnormal signal, and especially the change in signal by all readers. So I think if you think about the stir signal that we use to evaluate bone marrow edema, I think it's very important that readers do this consistently, from one scoring exercise to the next. So how do we accomplish that? You know, we do one scoring exercise 6 months ago, and then we repeat it now. How do we ensure that we're detecting the signal at the same threshold for sensitivity? And then it has to be measurable. Our calibration has to be measurable. So before people start a reading exercise, everybody approaches the exercise at a different level of expertise, a different level of experience and proficiency. So is there a way, are there tools that we can use to bring people together to the same level of proficiency? And can we use a metric that will ensure that people are at the same level of scoring proficiency before we start the reading exercise? So how do we attempt to do this? Well, the conventional approach has been to read the manuscript, put together an atlas, and this is very good for describing definitions. Then we might have an in-person group discussion around, I guess nowadays it will be online very much. And then we might do some reading exercises. And this is the advantage, of course, that it's feasible. It's relatively easy to do. You can standardize lesion definitions in an atlas. And interactive group learning is an effective mechanism of knowledge transfer. But the disadvantages, and there are some key disadvantages, it's first of all, it can be quite time consuming. The second is that depending on the setup, let's say you do an exercise, you then have to calculate the ICCs, then have to figure out where the problems are, and you can't really easily do the reading and the debriefing and the analysis all at the same time. You may not have the developers of the instruments readily available, or for that matter, people with expertise. And then learning dissipates. So you may have an interactive group learning discussion, but then what happens 6 months later? And there are, what about establishing benchmarks for success, that the knowledge transfer, the standardization of learning, detection of thresholds, all of this has achieved a certain benchmark of success. So I think that what we would like to discuss is something that's already been published as an OMERACT exercise, and that is the use of an online interface. And it's something that we call real-time iterative calibration. And we've now published this in several several OMERACT proceedings, and we validated it. And I think it is an option, an important consideration for us to move forward. It ensures universal accessibility. It allows us to generate pre-specified targets for reader reliability. In other words, it ensures that there's a certain scoring proficiency before readers begin a formal scoring exercise. And the platform ensures that there is expertise built into the platform. The developers, the experts aren't going to live forever. And there needs to be a way of conveying that expertise for the present and the future. So here's an example of something that has been developed for SPARC MRI SIG inflammation. And you can see that you have two type scans from two time points, in this case, case 14A, case 14B, baseline and 12-week scans, and slices are assessed for bone marrow edema, consecutive slices. Now, these scans have been scored by expert readers, in this case, myself and Rob Lambert. And you can see the schematic there, the scoring of the sacroiliac joint quadrants. And the blue is good, that means you're concordant with expert reader scores. The red means you're discordant with expert reader scores. You don't see the expert reader scores because that is built into the scoring interface. What you see is the discordance and concordance per the color coding. And so 50 cases have been scored and are available in the calibration module. They're pre-specified ICC targets. Status is an ICC of 0.8, and for change, the target is greater than 0.7. There's a similar calibration module for the sacroiliac joints. Here we have baseline and 2-year scans, because of course we're not going to see much change after 12 weeks. However, in adults, erosion can be reliably detected, change in erosion after 12 weeks. And there are the cutoffs that we use there. And we look at these cutoffs, they're based on expert consensus as to what is a reasonable cutoff based on a lot of scoring of structural lesions in the SIG. Noteworthy for the results of the first pediatric scoring exercise, where I think the ICCs aren't quite as bad as perhaps initially portrayed. And I just wanted to finish off by showing you an example from the scoring of lesions using the SPARC approach to the scoring of lesions in children. And so we have a pre-calibration set of ICC scores, which you can see in the middle column, and the post-calibration in the right-hand column. And you can see there wasn't much improvement in the inflammation scores, probably because they're already pretty good. This illustrates the number of cases that were available for scoring in these exercises for inflammation and structure. The same pre-specified targets for ICC were used for the calibration. So readers had to achieve these targets before they actually did the exercise. And you can see the only one that did not improve was sclerosis. And that might be because sclerosis is actually not included as a structural lesion in the SPARC SIG structural calibration module. But you can see substantive improvements in erosion. You can see that maybe for ankylosis, readers weren't scoring the same thing. And it was only after the calibration that we achieve a substantive post-calibration ICC. So the calibration module here has ensured that the method is being scored correctly. There's understanding of the scoring approach. There's understanding of the definitions, and there's an improvement that is evident in most of these lesions. Then this is a beautiful pictorial to show the pre and post for the various lesions, with ankylosis being most striking. So this is how I think we ought to proceed. I think we've made a good start. We've got our lesion definitions, they're standardized. We've attempted our first scoring exercise. I think overall we've had quite good reliability. And I think, how do we improve on this? I think we need to implement both conventional and new methodologies in a standard operating procedure framework. And I think this is the sort of approach that needs to be adopted for all scoring instruments. So calibration needs to be standardized, and we need to use validated tools. The JAMRI group, I think, should generate a calibration set of scans with consensus-based scores and 2 time points for a RTIC platform. And all readers, irrespective of experience, should be appropriately calibrated for future exercises. And I can tell you, over 20 years of working on scoring instruments, that expertise in diagnostic ascertainment does not necessarily equate with expertise in scoring. I just wanted to show you a statement from a review article from, I think, one of the icons of OMERACT, Marissa Lasser, in her article on the importance of standardization in the OMERACT process. To optimize standardization, an iterative process of calibration is needed on a representative sample. So I think I'll perhaps just end on that. Thank you for listening, and I look forward to your questions.
Thank you so much, Walter. It was really great to hear about novel methodologies that could be used to implement reliability studies. Would anybody have any questions to Walter?
Hi, Walter. It's Rob Lambert here.
Who?
Did we exclude sclerosis from the retic calibration module deliberately so that that domain would be a control?
No, actually we didn't. It's because we used the adult calibration module. Thank you for reminding me about that. We used the adult calibration module for children.
Right.
So that's why we did not have the sclerosis domain included.
But very, very interesting results, and it shows you how, of course, there's overlap with adults, but the definitions are not identical, and of course, the case material would not be entirely suitable, so that the development of a pediatric retic calibration module would be a tremendous benefit, I think.
Hi, it's John Carino. I have a question.
Hi, John.
Hey, Walter. To follow up on the last part, representative sample. So how, I mean, you would define that in terms of a spectrum of disease, right? So how many mild, moderate, severe cases do you think you need? And also, I think the representative sample also relies on the imaging. We talked about the pulse sequences. That's the contrast resolution, but I also think you need to specify a good spatial resolution. So first off is the spectrum of disease, and then second, I think, is do you define the acquisition parameters for the MRI?
Yeah, I think you've got two. There are two separate issues there. The first one is the acquisition parameters, and I think that the OMERACT JAMRI group should decide what sequences are going to be incorporated as part of a sort of standardized methodology. That's been done in adults, but I think it could be further standardized in children. With respect to the design of the calibration module, what we do need to ensure, I think, is that the cases do demonstrate some change, and there is some distribution of change. And we clearly see here our challenges to be able to reliably detect structural lesions. What's going to be even more challenging is to detect change in structural lesions. And so we need to ensure that our calibration set includes a distribution of cases demonstrating a distribution of change scores for the structural lesions. So very important questions, and that's something that needs to be further discussed, I think, within the group.
Thank you.
Thank you so much.
Well, Walter, can I ask you just one question also regarding the calibration? Is there any idea if there are differences between girls and boys or stage of puberty?
Well, we have just been scoring both males and females, and our focus has been on reliable detection of status and change scores. It is not intended to be an instrument for evaluation of diagnostic ascertainment. This is an instrument that focuses on reliable detection of lesions. And I think when we think about how we move further, you know, and we think about the OMERACT approach and reducing sources of variability, the face validity is very much focused on appropriate choice of lesions, but it won't address sources of variability. And a challenge at this point is addressing sources of variability so that we have a system that is going to prove capable of discriminating between groups and is responsive, because ultimately we want this instrument to be used in clinical trials. If it's going to be used in clinical trials, it must be capable of demonstrating discrimination between groups of interest. So that's what we're aiming for with the calibration tool. It's not designed to be a diagnostic instrument. It's designed to try and maximize discrimination.
Can I add a point there? And that is that we've shown that there is some variation between males and females as to what age certain anatomical or physiological variants will be observed. In particular, the subchondral flaring occurs later in boys than in girls. But if you correlate it to epiphyseal or physeal maturation, in fact, it's very close. So we've addressed that issue in the atlas, which shows how these physiological variants change with skeletal maturation. And through the atlas, I think it is dealt with that issue of gender variability.
Thank you. Thank you very much. There is one question from Simone Appenzeller about do we have to determine if the changes are clinically significant? So this is something that probably Walter already addressed for gender, but this also applies to clinically significance for this exercise?
Clinically significant is a difficult sort of concept, because when we think of clinical significance, we think of things like pain, symptoms, and then also maybe predictive utility. You know, what's the minimal amount of change that predicts a structural damage endpoint or something like that. I think may be an alternative but related concept that may be a more appropriate target for imaging evaluation is what is the minimally important change. So if you take, for example, BME, what's the minimally important change? That's been demonstrated to be 2 to 3 sacroiliac joint quadrants. That's something that a reader looking at a pre and post treatment scan to be able to determine if there's a clear-cut difference, you'd need to see bone marrow edema on 2 to 3 sacroiliac joint quadrants. So I think calculation of minimally important change is probably a more relevant concept for an imaging instrument.
Thank you so much, Walter. So now we're going to move to the next discussion on face validity exercise design. Mirka Maltolen, who is a PhD student, is going to discuss. We cannot hear you, Mirka Mal.
Okay, can you hear me now?
Yes.
Perfect. Yeah. Thank you all for your attention. I'm planning on I hope to describe this template research design to assess the face validity and kind of determine some sort of item weights so that we can use it to combine the scoring system into a single number to have like a holistic representation, evaluation of an image. And I think we may all agree that if possible, it would be good to have this single number to describe the patient's disease in terms of inflammation or damage. And because the JAMRI's SIJ is a multi-item scoring system, We can't simply just add up all the numbers, because right now it is the relative weighting now is currently just determined by.
We're not seeing any slides. Is this?
Oh, sorry. I forgot to. Let me just. There we go. So I was just on the first slide.
Okay.
Yes, because the JAMRI scoring system, it's a multi-item scoring system, it would be good to determine the relative weights between the items so that when we add them up, the way that the scores change in response to inflammation or osteochondral damage, that change happens in a more agreeable manner, at least in terms of its face validity. So that's why we want to do like an exercise, and hopefully a quantitative exercise later on in terms of determining the exact weights. But as a pilot to that, it would be helpful to determine some sort of ordinal level consensus statements in terms of the relative ordering of the different items. So let's say if the inflammatory domain has 7 items, it would be good that we, through some sort of a formalized experimental method, that we can kind of come up with like some sort of an a priori statement that we can validate later on. So such that, let's say item 1 is more important than item 4, and kind of determine this kind of relative ordering of the items. And also, if we use actual case vignettes in the scoring system, we can also determine the relative rank ordering of the case vignettes, which we can use for validative purposes later on when we actually get percentage weights for the individual items. We can do this through a discrete choice experiment later on, but for now, if we use 15 case vignettes, if we can get their relative ordering right and specified a priori, we can use that later quantitative study to see if the weights that it has produced is acting in a way that we have determined a priori, and also the item weights that have been generated in that subsequent study. So this is a pilot study to first look at like whether the items are applicable and whether the way they are defined and the way that they're graded have some face validity, and also achieve some ordinal level consensus statements, but in a more applied manner. Yeah. So this is an example of a case vignette. So basically, we're giving them representative slices where you can kind of have an impression of the different items that are present, and we give them as little information as possible so that we're trying to limit what they're basing their decisions on, because the only information that you should be feeding in to determine the case rank order should just be your impression on, or your opinion on, which item is more important than other. So your own expertise in terms of reading the images should not play into this. That's why we try to use as little information as possible to kind of standardize what you're working with in making the slices. We can discuss this a little bit more detail later, but I just wanted to see what kind of things that we would be expecting the participants to provide to us. So basically, like overall, we would ask them to rank a set of vignettes. So a vignette would be something like this, a single page showing the representative slices, and we might have up to 15 of it if that's feasible. So we'd ask them to give a ranking for the case, let's say with a sample of 15, and also for each case, for the items that are present, we ask them to record case-specific item ranks for the domain item. So this could be the inflammatory domain item or the damaged domain item. And also using this number 2, this case-specific importance ranks, determine a general importance ranks for all the items. Because not all vignettes are going to have all of the items, you would just give a case-specific rank order. And then using the what you recorded down for the 15 vignettes, you would come up with a general rank order. You'd repeat that for the damage domain. I'll show a chart of sample data from a user. That way it'll be more clear in terms of what we're asking. And later in a consensus meeting, we can discuss, so we would give this to a sample of experts, and we would include all stakeholders in this, not just radiologists, but also other clinicians as well. And we would ask them to just discuss aggregate results. So for example, case vignettes, if there's a spread, because there's 15 vignettes and each, let's say each of 30 participants will give potentially a different vignette rank for each of the vignettes. This can be plotted in a box plot of sorts so that we can see how much disagreement is there between the vignette rankings. And also we can see similar box plots to kind of visualize the importance, people's opinions on the specific item ranks, and also the general item ranks. And at that consensus meeting, we would, we'd discuss specific face validity questions. Because in this experiment, we are applying the scoring system into sample vignettes. This may generate some questions regarding the usability of the definitions, how helpful the items were in terms of coming up with an overall impression of inflammation or damage. So specific face validity questions like that would be discussed using these results. So we try to make this meetings as data-driven as possible. And also determine some general rank order by consensus and the raw score for the vignettes also to use for validative purposes for a subsequent quantitative study. And this is basically what we discussed. So we're asking each reader to give 3 pieces of information. So first is a rank order of the cases, 1 to 15, from lowest to highest level of inflammation. And also for each of the cases, so for each of the 15, we asked them to rank the items that are present, rank from 7 down to 1. So if there's only 2 items, you would just give a 7 and 6 and leave the others blank. And after ranking all the vignettes, give an overall impression on the items. Basically this, on the left-hand side, this big chart is basically what we would ask the participants to fill out. So for example, this would be the case ID, and this is their case rank. So ignore this for now. This is like the ideal case scenario, just to illustrate what the data might look like. So for example, if this item, whichever item it may be, if that happens to be the most important item among as many of the comparisons as possible, so you may notice that some vignettes won't have this item, so it won't receive a score in this column. But for the items that are present, so in this vignette number 4, it would only have 2 items, so you go from 7 and 6, and you go down the hierarchy that way. And the way that the data is analyzed is first this Excel chart would calculate the number of comparisons made between items. So for example, in this, so between item number 1 and 2, there were 1, 2, 3, 4, 5 comparisons made, 5 direct comparisons made between these 2 items. And so you would have a box here in this matrix. It would have a frequency tally of 5. So we do this for the entire set of potential comparisons. And also we would record down, let's say in this vignette, you made a specific comparison between these 2 items that were present. And you said that item 1 was more important than item 2. And this gets tallied up as a win for item number 1. And if you do this for the entire matrix, we can determine a frequency adjusted wins and losses for each of the items. And so this colored chart here helps you kind of determine, so this is like kind of your tracking sheet. and you would be making an overall rank order in this row. But this row can, if we decide to give them this matrix of information, you can simply say that, and this is generated based on the scores that you give. So this one got the highest coefficient. So this got a 6 and this one got a -6. And so you would think that, and basically this is a quantitative summary of your case wise ranks that you recorded. And this would help you kind of determine the overall ranking of the items. And maybe this is a more realistic data scenario. So for example, so I changed some numbers around. So these are all fake numbers, so don't get distracted. So let's say item number 5, it was present in only 4 cases, but when it was present, it was more important than, let's say, this item number 1. So this is a 7. Even though this one was receiving 7s throughout, when item number 5 was present, it got a rank 6, and this one got a rank 7. And so this chart, because it's a frequency adjusted, it helps avoid any biases in terms of case selection. So if we don't adjust for frequency, items that were more frequent would be overweighted. So this is a way of standardizing that. And you would get like this not so organized matrix. But then if you look at the number of wins, let's say, so this number 5, it won against item number 1, item number 2, and consistently across all items. And so that's why this produced a high number for this coefficient. So it helps you kind of determine, just basically quantify your case-wise rankings for the item importance into an overall statement. And we would have this chart done, we'd ask each participant to do this, and then we can produce some box plots to kind of help our consensus making process. So this exercise is to kind of make our decision making and evaluation more as quantitative and as formalized as possible. That's the end of the presentation.
So I have a question, if I may, and yes. I'd like to express a concern. So I think what you'll get when you do this, you say rank the importance of the domains. What you'll end up with is a ranking of lesions with diagnostic importance. And we're not building a diagnostic platform, we're building a scoring platform. So for example, you could take something like inflammation in an erosion cavity, and people may say, well, that's very important. That has high specificity for a diagnosis of XPAR. That is a very important lesion. And as a metrologist, I'd turn around and I would say, well, no, actually it isn't, because it only occurs in about 10% of your cases. And this is not going to be a lesion that's going to enhance your discrimination, your ability to distinguish between treatment groups of interest. Enthesitis, very important to pathophysiology. I would rank it very high in importance because this is important to me. I understand the pathophysiology. Enthesitis, highly specific lesion on MRI for pediatric SPA, very important. I would rank it way up there. But its reliability, it's very poor for detection, and its ability, its frequency is low, and its ability to enhance a scoring instrument so that it can discriminate between treatment groups is going to be very poor. So at the very least, what you ought to do is clarify what you mean by importance. And 2 is not just show a cross-sectional set of scans, you need to show longitudinal scans so that people can see what's happening, for example, with an erosion as it resolves, right? So because otherwise you'll end up with a diagnostic ranking of the most important lesions. That's going to be the tendency, but we're looking for a scoring instrument and combining these different, we don't know which lesions to include at this point in the scoring platform, but we want the most responsive, discriminatory scoring tool we can possibly get. And I don't think this, as it's currently designed, will take us there.
Mm-hmm.
Yeah, Andrea, if I can just add to that, I support Walter's comment. Be very cautious about confusing diagnostic instrument and outcome measurement instrument, which has no importance in it at all until you get to the bit where you're working out, does adding your scores up make difference? Is it important to add scores? Then you might want to develop weighted score systems and things like that. That's a very different process to this. So be cautious about diagnosis and outcome measurement.
I would also be slightly concerned about conducting this exercise based on selected JPEG images from selected cases. We're never going to be scoring cases that way. And so you might get a different result if you do the same exercise with DICOM data sets, where you ask exactly the same questions, only you give the observer the full DICOM data set. He can scroll backwards and forwards and make a similar evaluation, but with the ability to scroll in the window and magnify and do all those manipulations that we do when we're trying to ascertain with accuracy any component of disease.
Thank you so much for all these comments. I think they are really important. And I think if we undertake, this type of exercise, even debriefing about, what we plan to achieve out of this exercise, and if there would be another exercise later on, at the time of responsiveness assessment, or if we're going to do 2 exercises or just another one. So this is something that we plan to discuss after this meeting, but all these discussions and points raised were very important. So I think we only have 2 minutes left. Thank you very much for all the discussions. They were very relevant. We plan to have another meeting to discuss more in detail, especially the face validity exercise and all the points that were raised, during this meeting. And if anyone wants to have another point to be discussed, we have time for one more question, and then we are going to complete the session. I would like to thank especially the patients who participated in this meeting. Thank you for your questions. And if you have any further questions, please feel free to email me and Marion about any points that you'd like to discuss with us. And thank you very much for the students who presented and all the participants of this meeting. And it was a different format of a meeting, but it's always a pleasure to see our colleagues, even on a screen, and working together towards a very important subject that is the sacroiliac joint. And we have other working groups, the temporomandibular joint group, and also the whole body MRI groups, that we're going to have different meetings, not as part of the like a formal meeting such as this one, but we're going to continue having meetings to move different topics of study and exercises forward. So thank you so much, and I hope you have a pleasant end of the day. Thank you.